We are going to get started now for session 3. This is on our consumer perspective. Consumer perspective, we heard a few hints of consumerism in our first 2 sessions, but we need a lot more and more specific instances on that and insights on that. And we have 4 splendid panelists here who are not only well-versed in VBID and have some important experience there, but who bring some current kind of on-point experience with a consumer viewpoint. And I'm going to ask each of our panelists to introduce herself or himself just ever so briefly, and then a sentence or a few sentences about how you first got hold of VBID or how VBID might have gotten hold of you originally. And let's start with Jill Berger. Jill, can you get us started, please? Still on mute, I think. We have to unmute Jill.
Can you hear me now?
Yes.
So I'm Jill Berger with the Leapfrog Group. I'm Director of Employer and Purchaser Engagement. And before Leapfrog, I spent 20 years at Marriott managing their benefits. I came to know VBID because I think we and Pitney Bowes were one of the first employers to try to encourage our employees to do the right thing. For us, and actually I think for Pitney too, it was all around prescription drugs. And so we heard from our nurses at Aetna and Active Health Management at the time that our employees would call them and say, can you help me prioritize which of my meds I need to take first, because I can't afford them all. And we said, oh, this is an issue. Looked at our data. Compliance definitely was an issue. And so we wanted to take away at least that barrier. We know there are many barriers to compliance with medications, but so we did that. We made drugs related to chronic conditions, to diabetes, asthma, and heart disease free for our employees. So Marriott is an hourly population. It's a pretty low paid population. So definitely cost can be a barrier. And then we got together with Mark and Mike Chernow to measure what we did. And so that's how we got started with VBID. We did find that compliance improved slightly, which was really our goal.
Thanks very much, Jill. And that's we're hearing a lot about Marriott and Pitney Bowes among the earlier pioneers there. So Marge Ginsburg, tell us what you are doing and what you were doing and how you got the connection to VBID, please, Marge.
Thanks very much. So I'm the now retired but founding executive director for the Center for Healthcare Decisions in Sacramento. I do want to make an important distinction when referring to the consumer. Most organizations focus on the perspective, experience, and needs of patients. CHCD's role has been to understand the perspective of the consumer as what we call a social decision maker, a citizen providing input to healthcare policy. Through a process called public deliberation, in small group discussions, participants consider challenging healthcare policy and practice conundrums, ending with recommendations that they believe are fair and reasonable for themselves and for society at large. So with this background, I first met Mark and learned about the VBID Center at a small convening of Policy Wonks, sponsored by the California Healthcare Foundation and Health Affairs somewhere between 12 and 15 years ago. Though we had completed a project on cost effectiveness as a criterion for healthcare decisions in 2001, which, by the way, nobody paid any attention to because they had no idea what we were talking about. It really wasn't until I heard Mark speak and learn more about VBID that we were then able to start incorporating sort of fuller ideas about benefit design in our future project. So it was a fortuitous meeting. It started us off on a great path, and we're very grateful for that opportunity.
That was the connection. By the way, Marge, are you not involved with an organization called MedPAC?
Yeah, right. I'm currently a MedPAC commissioner, and just as an aside, I must say this has been a fabulous experience to go from 25 years of work with the consumer as a social decision maker and begin to bring that back to the broader realm of policy for Medicare. So
Good. It's not irrelevant that you are a commissioner. Thank you. Frederick, what are you doing now and how'd you get pulled into VBID?
Hey, Cliff. Well, thank you so much. It's a joy to be here. Thanks for inviting me to participate. I'm the executive director of Families USA. We're a national nonprofit, been around for about 40 years, and our mission is to ensure the very best health and healthcare are equally accessible and affordable to all in our country. That's what we work on every day. And a big part of our work is really thinking about how do we achieve health for families across this country. And I first really started getting involved in VBID in the mid-2000s when I was working on Senate Finance and Senate Help, and then going into the negotiations around the Affordable Care Act. As you know, VBID was a big part of the discussion as well there. And I was really struck. After that, I ended up at a place called the Advisory Board Company, a leading advisor to the healthcare sector, and I was a vice president there. And I remember that really seeing the difference between the public policy discussions around VBID and the realities that providers were thinking about strategically with regard to VBID. And fundamentally, I think, you know, what I saw was a real acknowledgement on the part of the strategic end of the healthcare sector, the providers, a real concern about the ability of VBID to undermine business models that were aimed at maximizing revenue and margin, but not necessarily providing the most effective, most deliberate healthcare for the patient populations. And that really excited me about VBID, to see how seriously the provider community took the potential for VBID to restructure their business model. I thought was really powerful. And now at Families, we feel really strongly that VBID is a really important tool to help consumers and families to be able to navigate our rather distorted and inefficient healthcare system to really achieve health in an economically viable way for their families.
It's helpful. It's interesting that you noted that even in the provider community, there was a disconnect between what they thought they were trying to do and the way the system was working. At VBID could provide maybe some kind of little boost or connection there. And of course, with the organization Families USA, there's an obvious connection there. I'm going to return to that in a few minutes. So thank you. John, you have seen much in this field evolve. Well, how did VBID capture your attention? You were a busy guy at the time. How did it kind of grab you, John? I think you're still on mute, John. I think you're still on mute, still.
Here we are. Is that better?
Yes, it is, sir.
Okay, so I was at ARP for many years as policy director. And what I remember, and now it was so long ago, I can't remember exactly when, Mark came to talk to me about value-based benefits. And of course, this fit perfectly into the mission of trying to improve healthcare, trying to improve affordability and effectiveness. And my focus was on Medicare. And it helped us become more effective advocates at ARP for stronger health promotion and prevention benefits, mostly focused on high value care. And I think that's the easy part of this. The last few years, I've been the president of the National Coalition on Healthcare, and it's a multi-stakeholder coalition whose focus is on healthcare affordability. And again, recognizing differential value is a key part of our strategy. What we're finding is different organizations implement it differently. We've had a terrific discussion earlier today here about some ideas, but my focus is to try to get policy changed, leading with Medicare, so that it's a system-wide characteristic, not just individual initiatives from company to company.
Got it. Thanks very much, John. So now you can see our four panels come at it from different angles, but there is a strong consumer root to what they've been doing. Starting with Frederick this time, set VBID aside for just a moment, Frederick. In your role now, I'm going to ask this of all of you, in your current role, given where we are with the, trying to emerge from the pandemic, a lot of social change, a lot of economic change, a lot of political change. Frederick, what can you tell us about consumer behavior these days? Doesn't have to be about VBID. What's consumer behavior looking like now? How is it emerging? And we'll maybe use that as a context for a little discussion in a few minutes. Consumer behavior, what's it looking like, Frederick?
You bet. Well, so, we are about to release next week a new national poll that we've completed of the American electorate of all political persuasions. And it's really about delving into where is the public on the question of health, action on the part of Washington to address healthcare needs or state capitals. And one of the most resounding results of that polling is that across the political spectrum, across geographies, rural, urban, West Coast, East Coast, doesn't matter, there is almost unanimity among the American public around the concerns that they have about being able to afford healthcare for themselves, and also that they're very concerned their neighbors can't afford healthcare. And that is really, I think, the most important theme that's emerging out of the pandemic. After we actually address, and the bill that is being finalized now and should be at the president's desk by tonight is probably it's one of the most important landmark legislations ever passed. I mean, there's so much in there to talk about, but it really does allow us to have a national response finally to the COVID pandemic, provide the resources we need to protect families' health and their financial security. It's projected it's going to lift probably more than 60% of children out of poverty. I mean, it is a really remarkable piece of legislation. But after that is all said and done, what are we left with? And what we know is that the American people, we have a crisis of healthcare affordability, and families are struggling. And I just want to say, I think that VBID is a very important tool to address healthcare affordability in a couple different ways. I can hold on that. It looks like you might want to know.
Let me push you a little bit more. So we see that coming out of the pandemic, among all the kinds of potential interests of consumers, healthcare is at or near the top. So that's an interest. And in particular, affordability.
Correct.
But what do you see insofar as how that might affect consumer behavior? So these are their interests. Do you see any kind of movement in behavior?
Well, that's a great question. The healthcare sector is so heavily distorted. There's so many classic market failures in healthcare that consumers don't respond in traditional ways, right? So, for example, if your hospital has tripled its prices in the last 2 years, say, you may not be aware of that because it's baked into your premium costs. So the answer of how consumers respond to the sort of mercurial or the vicissitudes of the healthcare sector is a tough one to answer. What I would say is that there's a couple things we know. One, there's a lot of warehouse demand that is probably going to be unleashed post-pandemic because people have really held back on some key seeking out healthcare for key issues that they felt could wait until they were the pandemic was subsiding. That's one big issue. Second big issue is that we know that where consumers are most price sensitive, which are where they're experiencing cost sharing, things like cost sharing related to pharmaceuticals, that's where they are most likely to activate around price. And we know there's a lot of work right now. Consumers are very, very exercised about things like prescription drug prices and, for example, surprise medical bills, which, that legislation was passed at the end of the year, where they really want to know that health insurance, their monthly premium payments, their commitment to caring for their family's health actually results not just in access to healthcare, but also real financial security. That's the other piece of this.
So that's very helpful. So there is warehouse demand. So there's this pent-up demand that could just kind of break out of the gates pretty soon. And then you might see some response to the issue of price and cost sharing. So that might also be a behavior influencer, as it were. So thank you. That's a very good basis. So Jill, from Leapfrog's standpoint, and even a broader one if you so choose, how is consumer behavior changing, or how do you expect it to change? Jill.
So one of the things I did when I got to Leapfrog is I put together a panel of employer benefit innovators. So they are our large national employers that come together and really talk about how to get the most value from hospitals and ASCs, which is our niche. And one of the things that I've seen that has come out of the pandemic, so a number of these employers do COEs, right? Centers of Excellence, where you fly to certain parts of the country and you are assessed based on your diagnosis. You are assessed, is the diagnosis correct? Is the treatment plan correct? And you know, they really have changed up the way that people are receiving care, because they find in many instances that it's not, their diagnosis isn't necessarily correct or the treatment plan. But enter the pandemic and people aren't flying. Flying's been curtailed, right? And so I think what's come out of that is there's this heightened focus on identifying high performing providers much more locally. And I think that's really important, because not only in areas where we know hospitals needed to improve safety practices, for instance, if the employers really rally them to do that, they make great changes. And so I think this will hopefully lift a lot of hospitals' safety practices.
Okay, so
The
in
other thing
search
is,
of, go ahead.
I was going to say the other thing is a lot of elective surgeries have been put off. And so there is, I think we're seeing it now, but I think there's going to be greater demand for these services. These services usually take place in the outpatient world. And Leapfrog just introduced an outpatient and ambulatory surgery center survey. And now we're getting a lot of support from the employers to get their ASCs to do the survey.
So the elective surgery part is an example, a healthcare example of Frederick's warehoused demand. And then you talked a bit before that about being in search of local high-performing providers. So again, these are two behavioral components. John Rother, all those years you spent at AARP is about a lot more than health. So I would think you'd have a broad consumer perspective. So from that perspective and/or that of the National Coalition, what are you seeing broadly about current or evolving consumer behavior?
Well, Cliff, let me make an announcement. I'm very happy to say the House has passed the COVID relief bill, and it's on the president. So
That's awesome.
Good news.
consequential pieces of legislation we could ever have worked on. But let me also say that I think this last year has revealed some serious issues around health equity, around consumer education and healthcare. The fact that we have so many people who are refusing to get vaccinated is a big reminder that even the most basic high value services aren't always well understood or acted upon in the population. So it's just a reminder that all patients, all consumers are not the same, and that we have huge, huge issues to deal with in certain parts of the population when it comes to understanding what's valuable in healthcare, even with the prompts. And so it seems to me we've got a bigger job than maybe we realize in terms of health communication and motivating appropriate behavior.
I'm glad you answered my question in the negative, because it was revealing. I'm looking for behavioral change, consumer change, changes in consumer behavior. And you're saying, well, notwithstanding all the other changes going on in society, some consumer behavior isn't changing. There's inertia, there are remaining barriers and hurdles. And so some behavior change that we might be expecting or wanting to see can't move. So that is an important point. Thank you, John. Marge, from your perspective, whether it's the current kind of MedPAC angle or your former angle at the center, what perspective do you have on consumer behavior change these days and or emerging consumer behavior?
Well, I'd actually right now have to speak with a somewhat different hat on. In terms of public deliberation, a lot of colleagues who are working on deliberative projects are focusing a lot on topics such as priorities for vaccine distribution, very, very timely issues, but don't specifically have to do with VBID. For the last 4 years, since I left CHCD, I've been a Medicare counselor with our state SHIP program. So this is giving me now going from the 3,000-foot level of what does the public think is most important in trade-offs to the individual level and how people want the decisions about what their Medicare coverage should be. And I'm not seeing a whole lot of change in the priorities people have. You know, number one, what's this going to cost me? What are my out-of-pocket costs going to be? What are the what limitations will I have on the providers I want? And what are the trade-offs I have to take into account when looking at the different Medicare options that are available to me? There is an interesting topic which has been raised so far, and that is telehealth. It's a topic I know MedPAC is looking at, a lot of folks are looking at. And to me, this represents kind of an interesting angle to pursue in a little bit more depth with regard to VBID. So I think most people regard telehealth with great reverence, and I'm a natural born cynic. So I'm always looking at new ways of providing healthcare, looking at what could possibly go wrong. And I actually think this could be an interesting issue for the future about, is telehealth high value care or is it low value? In the pandemic, it's definitely high value. Outside the pandemic, I don't think we know yet. So this is going to be an interesting topic in the future.
So you're saying we have seen some push for telehealth and even an expansion of telehealth intra-pandemic. However, you're wondering, will it persist? So that might be another kind of behavior change one way or the other. Interesting that you point that out, Mark. So Frederick, back to you then. Now back to VBID. Having thought through how consumer behavior and expectations are changing, Frederick, so if what you're trying to do is implement VBID, how do you do it better now in the current consumer environment? How do we make that happen? You started to get into it a little bit before.
Yeah, and I would say, and I just want to comment, I think Marge just made such an important comment. We definitely have also seen and done some work on the interest of consumers to lift up the telehealth experience they're having in the pandemic, to bring it into the, you know, sort of the new normal that we'll have post-pandemic. And I just want to say that I think at Families, we both share the excitement about that possibility, but we also absolutely share Marge's skepticism about how is it going to be structured so that it is high value. And I mean, I remember sitting in boardrooms with health systems that were thinking about massive auditorium-sized rooms filled with screens where they were providing massive quantities of telehealth so that they could churn away on the fee-for-service treadmill. And I think that was where my point was going to go, which is that fundamentally, I think VBID, you know, it's critically important in a couple different dimensions. The first is we know that right now healthcare costs that they continue to escalate at a very high rate, particularly over the last 10 years. And those escalations are putting enormous pressure, not just on family budgets, but on state budgets and on the federal budget. And that crisis is just becoming more and more acute. And so one of the most important dimensions of VBID is this notion that we are creating a way to create economic incentives that drive towards value and reduce potentially the overall growth of healthcare costs, if done well. I'm not being naive to say that VBID in and of itself could be responsible for that, but it could be an important tool in that direction. But the second piece of this that's really important to say is that there's often, especially when you sit in halls of Congress or in state capitals with governors, the typical line that is often given by providers to policymakers is two things. One, all we ever want to do is what's best for our patients. And two, if you just pay us more and get out of our way, we can do more for our patients. But when you get behind the curtain, what you understand is they are responding in a very profound way to fee-for-service economics, which are almost always in conflict with the interest of patients. And so the VBID model, one of the things it also does is it creates I would describe it as economic armor for consumers who don't have the ability to sit down and look at peer-reviewed journal articles and find out, is that surgery worth it? Is that drug worth it, right? It's an economic armor to help them to make the best possible choices for them and their families. That's a very different perspective from consumer groups have traditionally had, but we feel very proud of it at families.
Very interesting point. So you don't have to be a health economist to benefit from the economic armor afforded by VBID. And you're saying that the families whom you represent can be advantaged by that and have a better, more leverage or greater voice in decision-making with their providers, correct? Is that what you're pointing out?
What it allows the system to orient to the interests of the families and not their own pecuniary or economic interests.
Got it. John Rother, are you going to comment on that?
Yeah, I'm very sympathetic to that point, but I'm also quite aware that we have a long way to go with consumer understanding here. And let me just point a couple of examples. The concept of value and variable value in healthcare, we understand what we're talking about. I would posit that most regular people don't. And so we need new language. I would suggest the concept of waste, for example, would have more impact than talking about value. Secondly, we typically think that consumers only care about their direct out-of-pocket costs. That's not really true, as more and more people are being dealt with higher and higher premiums and higher cost sharing in general. Wasteful healthcare spending has a huge systematic impact on people and on the system that we've got to deal with. And then third, most people, particularly older people, are very, very deferential to recommendations from their physician. If we really want behavior to change, we've got to work with physicians directly. I've been involved in the Choosing Wisely effort, but we still have billions of dollars going to prescriptions for brand name drugs when generics are available. That's a problem with physicians as well as consumers. So it's got to be thought of in a more inclusive way so we get everybody on the same page.
And I appreciate your leaning toward getting the vocabulary right, John. So not so much value, which is kind of a messy, complicated concept, but waste. People understand waste.
Right.
You're pointing out it's not just about out-of-pocket costs, but those premiums are already quite daunting. And then how do you kind of retool the system to make it work for the docs? And so John, just back on this then, what then is from a consumer standpoint, is the first thing to do put across the idea of healthcare can be wasteful and it's bad for you too? In other words, if it's wasteful for somebody else or it's somebody else's money, maybe I don't care. How do you convey that concept to consumers in a way that will benefit them? And is VBID a route to accomplish that?
Yeah, I think VBID can be a way to accomplish that. The most obvious example is consumer anger at prescription drug costs. And where we can show, as an example I just used, that generics are a better alternative, that's an important message that still needs to get out to consumers as well as physicians. But then I would come back to one of my earlier points that we have a very wide diversity among consumers, and we have pockets of consumers who simply don't trust the healthcare system as it's currently set up, sometimes for good. So, we've got to work more on communication and on building trust so that they hear these messages about differential.
And your point echoes that which Mike Critelli made earlier about it's a pretty heterogeneous population out there. If you want to apply something like VBID, you really have to tailor it. And as you're pointing out, whether it's language or different perspectives, got to do it. So Jill Berger, then back to you from the standpoint of Leapfrog. How do we marshal or bring to bear these kind of consumer perspectives in a way that can involve or engage your members at Leapfrog? How do we make that work?
Excuse me.
And they're looking after or on behalf of some of these consumers, of course.
Right. Exactly. And, consumers come in all different shapes and sizes. I mean, I'm harking back to my Marriott days. So Marriott's a very diverse population. And we worked pretty hard on how do we communicate to our members the best way for them to get care, and to get to the higher quality providers, to get to the prescription drugs that we need. And it's hard. We did a survey of our members who had and taking advantage of, or some of the members were taking advantage of the free or the no co-pays for their drugs related to chronic conditions. But we expected client compliance to way high, and it didn't. I mean, it improved, but not like we thought it did. And we did focus groups with our members, and I would say 9 times out of 10, even though there were many times they didn't pay anything for their prescription drugs, they didn't know it because the co-pays varied widely anyway. There's co-pay for brand name drugs. There's a co-pay for generics. There's a co-pay for brand name drugs that aren't on the formulary. And then there's a co-pay for VBID. And so that was our challenge so they kind of ran into it. Yeah, maybe compliance went up because they became more affordable, even though they didn't understand why. And so even as I think about Leapfrog and I think about our value-based purchasing program, how do we communicate to members? We have data out there that will help you choose the safer hospitals. How do we get them to use it? And a lot of times we have some employers that are playing with plan designs now, making it free, making it so that they don't, their members don't have to pay anything for the premium if they take the value plan, or playing with co-pays or things like that.
So Jill, you pointed out a couple times Marriott, we heard about Pitney Bowes as well. So what is going to be the next appeal to companies of VBID? In other words, those are key players, they were pivotal players. How do we grab the next set of pivotal players in the industry? What's that going to be? What's it going to look like?
That is an excellent question. So how do we get more employers entering the game? Is that what you're saying?
Yes. Yeah. What's going to grab them?
Well, I'll tell you that, I said earlier, the pandemic is kind of helping us. First of all, employers didn't pay as much for healthcare, for claims, the self-insured employers for 2020. And they kind of liked that 20% decrease or whatever it was, because people stopped receiving care where they didn't have to. And so what I'm hearing from our panel of benefit innovators is, hey, we like this, and we're going to start implementing plans where we can get people to the higher quality providers. Maybe we make them do it, or however they're going to do it. And we can take the noise now, because we don't want these costs to come back.
So the pandemic did influence their outlook then
Right.
in a big way. All right, fair enough. So Marge, just kind of reflecting back on your experience and or your MedPAC role, and even though the third role that you mentioned before then, so what can we say about a more appealing VBID to those consumer perspectives now, looking ahead? What would work now?
Well, actually, I was going to kind of take the opposite, which is
Oh,
not to make it more appealing, but I wanted to focus a little bit on our findings about low value care. So we did at least 12 projects between 2001 and 2016, all of which incorporated the concept of low value care within the domain of the project. We also did a joint project with the VBID Center where we explored both low value and high value in people's perspective. But what I wanted to do is just summarize some of the key points about the really difficult challenge, and that's how do we reduce low value care, which I see as a much bigger issue for health policy makers than continuing to work on high value, which we need to do, but it's the low value that's problematic. Okay, so
but that's what VBID-X is. That's what VBID-X is. So enlighten us.
it is.
Tell us.
Okay, so I just wanted to mention a few findings of what we hear from the public when we
Please.
press them on low value care. First of all, and I think all of you know this, if the concept of low value care is coming from their health plan, forget it, okay? Anything coming from their health plan is going to be suspect. End of story. If it's coming from their personal doctor who they know and trust, okay, then they're willing to listen. Then they're really ready to accept it, to move forward. Where low value care is associated, the kind of medical problem or issue, makes a difference to folks. So if people are looking at low value interventions having to do with dealing with complex chronic illness, they're much more accepting that in fact there are other ways to treat chronic illness. If it has to do with a catastrophic incident where somebody may be on the verge of dying, not so much. They want to give somebody who might be dying every possible realm of opportunity, even if it probably won't work. So where it's planted within the healthcare menu is an important piece. One theme we heard from the public universally, every project, and that is the public looks for compromises. They really don't like dramatic yeses and dramatic nos. They're always looking for, well, how about if we just do it this way? We shave a little bit off. That was a very positive finding for the concept of don't tell people they can't have the MRI for their low back pain. Charge them more, increase their cost sharing. That
Sounds
is
familiar.
much more acceptable to them than being told no. So I'm presenting these just as general viewpoints of where the public is on issues like this. There will always be a cognitive struggle between the public's acceptance of professional guidelines and the belief that all patients are individuals. And therefore, yeah, you got these guidelines. They're based on solid research from physicians we trust, medical experts, but you know, everybody's unique. So where do you find that balance? That will always be a big issue. So anyway, those are the main things that I wanted to present. There are a lot more. I also wanted to mention, I did include a list of references, which I don't know how they might be handed out, but I would encourage those of you who are interested in learning more about the public's views on low value care to get that list of references.
I would guess that the VBID staff may be in touch with you for a link to that. Marge, I so much like the point you made about the source of that advice. Health plan, no. Healthcare provider, yes. But then we've got to go back to John Rother's point about sort of how do you appeal to them, to the providers, to actually change their behavior in a way that's more consistent. So just a quick closing question. We've just got a couple minutes left. And I'm going to ask you to do this. And so I'll pose it this way. If you wanted the consumer, however you want to kind of think of the consumer, if you wanted the consumer to derive the greatest benefit from VBID, and will include high or low value care, if you wanted the consumer to derive the greatest benefit from a VBID-like concept within the next 2 to 5 years, so not tomorrow, but not a decade from now, what button would you push, what lever would you pull to enable that? Okay, so basically we want to kind of empower the consumer for VBID, but we got to push a button or pull a lever. Fred, what would that be in just a sentence or two? Putting you on the spot.
Sure. Say, first and foremost, that VBID isn't an optional part of the insurance design, the design of insurance. I think VBID, if people really understood in healthcare and how much fee-for-service economics were driving providers against the interest of their own patients, VBID would be mandatory. That would be the first thing. That the design of VBID is a main part of insurance design. The second piece would be that there was a lot of intentionality about the way that VBID integrated it into other payment delivery methods, and in particular things like, if you think about for example, the Maryland model, the Maryland Care First model, where they really empowered primary care physicians to understand what waste was and the referral patterns to specialists. And if you linked that kind of financial incentive from primary care to a VBID insurance design, you can see a lot of really powerful behavior change.
Make that link. Thank you very much. Jill, in just a sentence or two, how do we empower the consumer for VBID? What would it be?
We have to get more employers offering this. That's
on you,
thing.
Jill.
That's on me, and I'm working very hard on that, and making inroads. Not as fast as I'd like to be, but making inroads.
Thank you very much. Great. Marge, you might have already answered my question before, but how would you empower the consumer for VBID or low value care, however you put, please?
I think, and again, since my realm is more on Medicare these days, I think it would be possible to design a Medicare Advantage plan, or maybe even a Medicare supplemental plan for original Medicare that incorporates VBID in its structure and makes it available at a premium people are going to be interested in. Right. So bring them there by lowering the premium, but make it really clear exactly how this works.
Hit on the premium, and that brings us back to John, who actually did say something earlier about premiums in addition out of pockets. Thanks for the point, Marge. John, what would it be? Your short version.
On some of the earlier comments, and go back to what Karen actually was talking about too. I think that giving Medicare more flexibility to address social determinants and lifestyle, all the things that we know drive healthcare cost and health status, would lead us inevitably to a much greater appreciation for value-based care. The second step though is you got to get physicians in the game, and to do that, we've got to move away from fee-for-service. So change the way doctors are paid, broaden the benefit package to include social determinants. Those things would be a major opportunity to adapt value-based care.
So enhance Medicare flexibility to pull in these services and say bye-bye to fee-for-service medicine. John, we'll leave that up to you to accomplish in the next couple of weeks. Now that we've set aside the bill, accomplish that today, that's your next job. So, okay, great thanks to Marge Ginsburg, Jill Berger, Frederick Sassi, and John Rother. We needed that consumer perspective. You gave us a few surprises, I will admit that, but you gave us some great ideas about how to broaden this, and you're all, sometimes I think you're braver than I am. You're kind of really reaching for something that you're telling us with your experience is doable. We hope so. Thank you very much. Great panel. Thank you, consumer folks. Bye-bye.